Hello and happy Teach Me Tuesday. My name is Lisa Houston and I am a clinical nurse educator specializing in NICU education. And there's been a delay in this video and I'm sorry about that. So here we go, another attempt. Hope it goes well. Today we are talking about delayed cord clamping, and we're going to talk about kind of the history behind it, which I love digging into, where all these fun things come from, and the evidence, the fears of what it was going to do to bilirubin, and of course helps with preventing IVH. But delayed cord clamping involves waiting at least 30 to 60 seconds before clamping the umbilical cord after birth. This is really important for our NICU babies because it can increase their blood volume, improve their oxygenation, and in turn reduce their risk for IVH. The whole thing about delayed cord clamping that I kind of love about it, to be honest, is that it really requires a partnership and a collaboration between your labor and birth or labor and delivery or OB team, whatever you call it on your unit, and the NICU. It's not just that we have to believe this, but they also have to believe it, because most of the time it is going to be the OB team who is first determining what a vigorous baby is. Second, kind of doing that countdown of waiting and being there with the baby, keeping them warm and stable during this time. And honestly, there has to be a collaboration so that they can also say, hey, the baby's no longer vigorous, I'm going to cut the cord. So this is how we're going to make sure that these newborns transition more smoothly to life outside the womb. They're no longer in their womb life. So how did this begin? So delayed cord clamping, I thought this was so interesting. First of all, I don't know or had not heard of Erasmus, probably mispronouncing that, Darwin, in the late 1800s really being a part of saying, we should really see how long we can go and let the cord stop pulsating, have the baby take some breaths before we clamp it. But we in the NICU, when I started my career, I've been a NICU nurse for almost 21 years. And when we started our career, I started my career, delayed cord clamping wasn't a thing. And to be honest, I think that some of these things that we do, at first when we hear them, we're like, ooh, that's what the, I like to say hippies, I hate that word, but the crunchy people. Same thing with donor breast milk. There was milk sharing going on well before we started doing it in the NICU. And what we do in the NICU obviously is much safer with milk, and now it's pasteurized and everyone goes through all the testing, etc. But at first you hear these things and you're like, why would anyone want to delay the clamping of the cord? We should be doing that quickly. And honestly, we now know how good it is for the baby. So sometimes you hear these wild ideas and then you think to yourself, maybe that was probably a good idea. But really, it is a new practice. Really, the evidence started to be gathered with these randomized controlled trials in the 2000s. And then in 2010, so I've been a NICU nurse by 5-6 years at that time, we started thinking to ourselves, who should we do this for? How should it happen? And then we realized over long-term studies that it was reducing the number of blood transfusions babies were getting, which has its own risk. So we now realize, and NRP recommends, that we do delayed cord clamping for 30 to 67 seconds for all vigorous infants. It's a big statement. So this obviously begins with these conversations with the OB team. We need to collaborate with them. We need to know what our protocol is going to be, who qualifies for it. Are we going to be doing it during emergent or emergency C-sections? Are we going to be able to do it if it is a vaginal birth that is a precipitous delivery that maybe our team's not prepared for? Do we need to make sure that the room is at the right temperature, that we have pre-warmed sterile towels for those babies born via C-section that need to be born into a sterile environment? So it's not just this thing where we can say like, oh yes, we're going to do this immediately. We have to really work with our OB teams to make sure that we can move forward into the next steps, which is going to be our steps for implementation. So first we need to have standardized guidelines. Who are we doing this for? How long are we doing it? How are we going to define vigorous? Who's going to define vigorous? Who is going to be catching the baby and holding them there? What kind of towels are we going to catch them into? Are they going to be pre-warmed sterile towels? Do you have blankets that are sterile so that the baby can stay warmer? What is that going to look like? Can the baby go on mom if maybe they're a late preterm infant? So just lots of little nuances to who this is best for. We then need to have education, and of course my favorite, having a simulation with your NICU and labor and birth team is going to identify the gaps in your protocol and help you realize, hey, maybe we need to do this a little bit better, or this didn't quite work out. How can we, make sure that it's a smooth transition between coming out, doing the delayed cord clamping, and getting the baby to the NICU. We need to make sure that we have the right equipment for this. Maybe in your facility, you're placing the infant into the poncho or their plastic wrap during this time. Maybe you have a sterile poncho. Maybe you've decided that that is not the best way because there's too much fluid getting in, whatever it might be. We wanted to make sure we're monitoring the infant the whole time. So that's more of looking at, are they vigorous? I don't think it's reasonable to think we're going to be able to put a pulse oximeter or have someone listening to see what their heart rate and all of that are. My dog is like excessively making so much noise right now. I'm so sorry. And then we need to get this in place and say to ourselves, hey, what can we improve on? What did not work? What was kind of confusing in this scenario? Maybe we thought that it was going to be great with the sterile towels, but the sterile towels actually were rough on the infant's skin. We need to change to blankets and have that ongoing protocols. So how do we know who should get delayed cord clamping? Obviously, we really want it in our preterm infants, but there's really no reason to say no if it's kind of been this normal vaginal C-section delivery, no matter the age of the infant. We really want to think more about the exclusions. So we want to exclude this for any infant requiring emergency resuscitation, maternal emergencies, placental abruption, cord prolapse, mom's hemorrhaging, the mom's coding. Maybe we have an amniotic embolism, like something like that, where there are those major issues. We do not want to be delaying the resuscitation on these babies or risking the idea that maybe the mom's blood volume is low. We, of course, would want to try to get everything circulating back to her. And then with congenital anomalies that need urgent intervention, whether that's intubation or getting a myelomeningeo covered or a bowel in a bowel bag. So more think about who shouldn't get it, and everyone else should just get it. So that's kind of an easy way to put it. And when we think about that, we also just need to think about, when would the NICU team intervene? And when we think about that, we're going to talk about, what does vigorous mean? So NRP tells us that a vigorous baby is breathing or crying, which means their heart rate's probably greater than 100, has good muscle tone. We can count the pulse on the umbilical cord, right? But during delayed cord clamping, you're not seeing somebody over there with a stethoscope, literally counting it out. Breathing and crying, anytime a baby is crying, you have to think to yourself, their heart rate's good enough that they have enough cardiac output to be crying. So that's great. You're doing great. And if this is great, our preterm burst, we're going to do it for our term burst. But for our non-vigorous babies, we may still initiate a brief delayed cord clamping. Maybe we'll give them a little stimulus. The OB will be down there giving them a little, rubbing, patting, and waiting for the baby to be brought over. But if the baby has any signs of instability, bradycardia, apnea, no crying, no movement, then we will have no delayed cord clamping. And maybe the baby comes out nice and vigorous, and you're like, okay, start the timer. They will have everywhere I've practiced, we started the Apgar timer on our warmer and said 30 seconds when they get to 30 and 60 seconds when they get to 60. At any point, the baby may become unvigorous. The OB may try to do a little, stimulation, but otherwise we're going to then clamp the cord and bring them over. Just because you start delayed cord clamping does not mean you have to finish it. So watching for those signs of vigor, and this goes back to NRP. What does a vigorous baby mean? Breathing or crying, good tone, watching their movement, watching their respirations. That's kind of what we're going to be looking for. So a big concern when delayed cord clamping start happening is, what's going to happen to bilirubin? Will the bilirubin go up? Will we have these babies in really dangerous levels where we're having exchange transfusions, or we're seeing a connectorus or something really big? And really that didn't happen. Yes, we saw that the increase in red blood cells may increase the bilirubin levels, but it wasn't getting so high that it outweighed the benefit to delayed cord clamping. So you may have seen an increase. I want to say this was as my Lisa statistic for today. In my experience, I haven't seen a baby born under 34 weeks, so a premature infant, not already need bilirubins checked frequently and getting phototherapy. I have not seen my experience in my career, and I have not found any evidence that delayed cord clamping caused an extreme rise in bilirubin levels, which then caused us to have to do more procedures. So that is not out there. There's no evidence to support that claim. It was a concern and it was something that was followed. So good to have concerns and to know what's happening. So what are the risk factors? Really, this increased risk of jaundice, delays in initiating resuscitation, the complications, but the risk factors are really low as long as you've had that really good communication with your OB team. You have clear protocols for what this looks like, when delayed cord clamping is not feasible, when we shouldn't be doing it. If you have all those in place, it really mitigates those risk factors and actually makes this a very low risk intervention with high possible results. So some of those results are going to be about IVH prevention. There is an article in the Journal of Pediatrics where I did a lot of my digging. And so if you're interested in that article, please feel free to message me. But really it's shown that the delayed cord clamping can significantly reduce hemorrhage. It gives them this starter of life with like this bigger blood volume, which in turn also is going to decrease your risk for blood transfusion. So blood transfusion is one of those things in the NICU that we absolutely have to do at times. So I don't want to scare you away from blood transfusions, but the idea that we could reduce the frequency of them. We also know that there is a deep investigation into the causal relationship between blood transfusions and NEC and which one kind of was the chicken, which one's the egg. So anytime we could just give, and you're exposing them to more donors as well, right? So just all of those things, less transfusions is always going to be better for the babies. If we have this improved cardiovascular stability, circulatory stability, it's improving our cardiac output. Those things are going to prevent your hypoxia and your hypoxemia. So overall, we're just doing some improvements here. There was a study that showed this Journal of Pediatrics that there was a 50% reduction in IVH with preterm babies compared to those with standard clamping. I mean, I'm just like pausing for effect. It seems like if you can get a good conversation going with your OB team, the risk here really is low compared to the benefit. And this is just all about having more blood volume. That's the patho behind it. More blood volume, more circulation, better cerebral perfusion, better cardiac output, less risk of hypoxia and hypoxemia. So good, good, good all around. I think that delayed cord clamping, even like some far-reaching parts of this, such as lotus bursts or cord milking, all of that, this is way more common knowledge than it was 10 years ago. So it's likely that your parents are already going to know about this. They may ask about it prior to the infant's birth. Of course, whenever we're having a conversation with a family prior to a preterm delivery, we do want to tell them like, hey, this is our goal. Our goal is 30 to 60 seconds, depending on the activity of your baby. Probably don't tell them the vigor of your baby because they'll be like, what are you talking about? But depending on the activity of your baby, our goal really is, can we do this for 30 to 60 seconds? These are the benefits. Yes, there is some risk. Maybe in some of these late preterm infants that we're trying to avoid the NICU, they would be more nervous about it because maybe it's going to increase their risk for needing treatment for their jaundice. So something you may need to mitigate, but overall, this is a benefit for the baby. And if it is a late preterm infant and the baby can be right on mom, the delayed cord clamping can still be going on. We're not going to skip out on skin to skin as part of this delayed cord clamping. So we've talked about a lot. We've talked about the history behind this, which I still think is fascinating. I still think it's fascinating that things are adopted in some communities before we're quite ready for them, but we like our randomized control trials, which I very much appreciate about delayed cord clamping. There are many, many out there that you can read. I've only highlighted a few today, but I recommend you go out if you're looking to implement this on your unit, if it's not already happening, or you think that there's a protocol in place that's maybe not being followed. Go do your lit search, find the articles, bring it to your team so that we can show that there is a positive effect on oxygenation, circulation, long-term health. How can we really show that these benefits are going to outweigh the risks? How can we train our staff? And how can we let them know what is the best steps for the premature babies and term babies that are born in their hospital? Thank you for joining me for today's Teach Me Tuesday. I will see you next week where we will have another breakdown of a NICU topic. Have a great week.